All right, I think we'll go ahead and get started. All right, so today we're starting our last chapter. So we're taking a look at Medicare and Medicaid. So a couple of different types of government-provided health insurance. Um, Pretty important in the healthcare market. They play a really substantial role in providing health insurance to sort of, I guess, underserved groups. So that's what we're looking at today. um, and uh, and then we'll wrap this up on Wednesday. But previously we looked at sort of the private provision of health insurance, and the issues related to the supply of it, as far as like loading fees and taking on risk and all those sorts of things. But today we're looking at Medicare and Medicaid and all of the wonderful different things involved with that. So for your learning objectives, look out for sort of these issues. Um, so first of all, we want to learn sort of the basic features of all these different programs. So that includes Medicare and Medicaid, and also something called Supplemental Children's Health Insurance Program, or SCHIP, and kind of how they developed and originated and evolved over time. So look for those issues. Then, of course, we want to understand the sort of the implications, economically speaking, of these programs and their design features, right? Because they're all kind of designed in different ways, and their design evolved over time as well. So looking out for the economic implications of all those things. And then we're going to look at like some of the specific modifications to Medicare. Oh, we lost Bella. Hopefully she can join us again. Looking at the modifications to Medicare, particularly the payment mechanisms, how payments are made to hospitals and physicians, and again, understanding the economic implications of these things. And then looking specifically at how these capitation programs that we've seen previously, like HMOs and PPOs, how they work within the realm of Medicare and Medicaid, and also understand how things, something called risk adjustment mechanisms can affect sort of the efficacy and value of these programs. So be looking out for those things. All right. Glad you're back with us. All right, so this all started back in the 60s under the Lyndon B. Johnson administration. And at the time, he signed into law a couple of titles, um, adding them to the Social Security Act. So these were titles 18 and 19. Title 18 established Medicare, which is basically, in a nutshell, mandatory universal health care, or health insurance rather, for the elderly initially, and then later on it was also amended to include coverage for permanently disabled people, as well as people with kidney failure, I believe. And then Title 19 created Medicaid, which is very similar in a lot of ways, except it's targeted at people that are below the federal poverty line, so people that are low income. And Medicaid works a little bit differently because it works through sort of federal state partnerships. So the federal government and state governments working together. And so there's actually a little bit of variation from state to state, depending on how they set up their Medicaid programs. We'll see that later on. And so this represented a huge transformation in terms of the government's involvement in the medical care system, something that really hasn't been matched since until the Patient Protection and Affordable Care Act in 2008 and 2009. Or I guess it was passed in 2010, but it was being developed in that time frame. So pretty big deal, right? A huge change, something the U.S. federal government had never really been involved in before was healthcare. So pretty substantial. Now, at the time, this is pretty early on, even for normal private health insurance. So the economic consequences were not well understood at the time that it was developed, and it kind of shows, as we will see, in terms of the cost structure and everything. The designers of these programs really didn't have a good understanding of what was going to happen, which kind of led to all the changes that took place in the following decades that we're going to look at. So, and that was mainly because there weren't any studies at the time that looking at the effect of health insurance on medical care demand. So there was really no way to predict it. But as time progressed, it became very obvious that controlling costs was a major issue. And so as time went on, changes started to be implemented that were intended to limit spending, try to limit spending, because it was kind of running amok. um, and actually, these changes that initiated in Medicare and Medicaid worked so well that they actually spilled over into private insurance, and that's actually where the evolution of managed care came from, was from the changes in Medicare and Medicaid aimed at limiting spending. So, and we've already seen that, right? We talked about that last week. And then more recently, there have been additions of new programs. So originally, Medicare included two parts. Part A, which was the mandatory part. So anybody that was 65 and older that was receiving Social Security benefits had to be enrolled in Part A. And then there was a second part, Part B, that was optional. Now, Part A was purely for hospital coverage, so just covering hospitalizations, which at the time was like the most common form of medical care took place in hospitalizations. So it makes sense why they fully covered that and made it mandatory. And then less common was sort of physician visits, right? It's not like today where people go to the doctor regularly and things like that. Physician visits were much less common at the time, which is why I think they made Part B, which covered physician services, they made it optional. So you didn't have to enroll in it. But more recently, there's a new Part C, which is called Medicare Advantage. And what this did was it expanded the ways that people enrolled in Medicare could use private insurance, perhaps supplementally. And then a bit later, beyond that, Part D was added, and Part D added prescription drug care. Prescription drug coverage to the list of things that were covered. So, and then one other thing that was created or added to the program was called the Supplemental Children's Health Insurance Program, SCHIP for short. So we'll look at all these additions in detail in just a few minutes here. But at first, we're going to go over sort of the initial structure, right? How did it start out? So there were really only two examples in the real world to look at to sort of model this program after, and that was sort of the private insurance at the time, which kind of had two flavors. There was the Blue Cross insurance coverage, and then there was also what was called major medical insurance, which really only covered major medical procedures. And so what the original designers of the program did was they kind of took the Blue Cross model as their basis, and in fact, they basically copied it. But as we've kind of already said, hospitalization and hospital care was kind of the priority, and so it was ultimately initially fully covered. And then the Part B, which covered physician services, wasn't fully covered. It was paid for with an initial deductible. There was also co-insurance involved, and then there was a fee schedule that itemized the amounts that would be paid to providers for any given procedure. And like I said earlier, the program started with Parts A and B, and Part A was mandatory. for anyone receiving Social Security benefits. And it was funded through what was called the Medicare Trust Fund, which was funded through basically income taxes as well as a Social Security tax. Now, although this Part B was entirely optional, the premiums for it were so low that almost everybody that was enrolled in Part A also enrolled in Part B because it was so heavily subsidized. Um, Now, the designers really had no idea what the costs of the plan would be, but they were trying to target basically covering about half of all costs with premiums. So that was what they were kind of aiming for, was to cover about half of the costs with premiums. Um, and then that turned out to be kind of difficult because they didn't know how, how people were going to respond to this coverage. Um, Now, in 2008, the premium was only $96.40 a month. But then in 2010, I think with the uh, Patient Protection and Affordable Care Act, it was made higher for individuals that made more than 85,000 a year. So after this adjustment was made, if you made it more than 85,000 a year, I think that's for individuals, not households. So individuals that made $85,000 a year or more kind of had the premium would scale up, but that was ultimately capped at just under $370 a month. Right. So, like I said, at the time, the predominant insurer providing hospital coverage was Blue Cross, and they kind of had these interesting plans where basically they offered either 30, 60, or 90 days of hospital care, but then nothing after that. So as soon as you hit your limit, you were on the hook for the bill after that, right? Um, and so at the time there was kind of this even split between the Blue Shield, and Blue Cross, and then these other types of commercial insurance, and Medicare decided to adopt the approach of the Blues. So this 30, 60, 90-day coverage. All right, so Part A covered hospital care, and they did it on a per episode of illness basis. Um, and so it kind of worked like this. So basically, the deductible was in the form of paying for the first day of hospital care. So the first day of hospital coverage, the patient paid the U.S. average cost of hospital care, daily cost. And so that kind of acted as the deductible. So in that way, it probably helped prevent some use of this coverage just by having sort of kind of like a barrier to entry on this first day payment. But then after that, um, the first 59 days after that first day, I guess, Medicare covered 100% of the cost, and then it kind of scaled it down from there. So if you had between 61 and 90 days of hospital care, then at that point the patient had to pay a 25% co-insurance rate, and then of course Medicare paid the other 75%. And then between 91 and 150 days, the co-insurance rate went from 25% up to 50%. So between those days, in that date range, patients paid 50% of the coverage. And at the same time, they were drawing down on what was kind of like a lifetime reserve of 60 days. So the plan included this 60 days of reserve coverage. Um, so basically, any amount of hospital care beyond 90 days started eating into this extra 60 days that was provided over the rest of the lifetime of the patient. So once they drew down on these 60 days, those 60 days are gone, and then they only had up to 90 days of coverage in the hospital. Now, once they ate up those 60 days, Medicare doesn't pay anything after that. So, but man, can you imagine being in the hospital for 150 days? That would be terrible. um, let's see. Whoops, that was left that in there accidentally. But this first day deductible, right? The first payment for the first hospital day basically tracked the daily U.S. average for hospital costs all the way up until 1987, and that's when the first changes really started to appear. So, starting in 1987, Congress established a new deductible. They set it to $520, and then they also created some new rules for updating it, right? Because it hadn't been updated since its initiation in 1965. And basically, the changes that were made it so that the cost very closely tracked the CPI. So, a way to try to adjust for inflation over time, right? Um, and so, just to give you an idea of some of the changes, how the deductible changed over time, the Part A deductible had reached just over $1,100 by 2012. So much larger than it had been, right? And basically, the program was providing what's called a first dollar coverage. So covering like the initial costs of hospitalization, but there was really no serious protection from catastrophic risk. So, if there was no coverage for really bad things like going into a coma or losing your limbs or anything like that, where you maybe had to be in the hospital for close to a year or something. There was absolutely no coverage like that. It was really only providing coverage for sort of these initial costs, right? These first dollar coverages. Now, while Part B is labeled as physician care coverage, it really does provide more coverage than just physician care, but most of the expenditures involve physician services. Um, and with this, the designers actually followed, instead of following the Blue Cross Blue Shield model, they followed the other major medical insurance type plans that essentially covered all services after an annual deductible was met. And then the plan also includes co-insurance rates for all procedures. So there's a deductible. Once the deductible's met, then there's co-insurance rates for procedures. So just to get an idea of what it looked like, the annual deductible was very low, $50. So that would be covered almost probably within the first or second physician visit, if not the first, certainly the second. And then there was a 20% co-insurance rate, and then a fee schedule to pay providers. So providers couldn't determine their own price, right? The price that they would be paid for a procedure was determined by the government. Then over time, the deductible kind of irregularly increased. It increased to $60 in 1973, then to $75 in 1982, then $100 in 1991, and then finally $110 in 2005. And then currently, the deductible is now set up so that it's proportional to the rate at which average Plan B costs increase. So again, trying to tie it somewhat to, in this case, not CPI, but some measure of medical inflation, right? So the issue here really is that it's increasing faster than general CPI, and that's because rather than following CPI, it's tied to the average Plan B costs. And of course, medical costs are increasing faster than the consumer price index, and so is the deductible since it's tied to the average medical costs. And so to give you an idea of how big it would be if it followed CPI, the original $50 deductible would be $360 in 2012. So it's actually higher than that now. All right, any questions so far? Okay. All right, so now we're going to start talking about some of the additions, right? The newer things that have been added to the sort of original design. So the first one is Medicare Advantage, which is also known as Part C. And this basically gives people some options, people that are enrolled in Medicare, it gives them options to enroll in various HMO plans. So these managed care type plans that we saw in the last chapter. Um, and these plans have to cover the same services that that Medicare covers, but it doesn't have to cover them necessarily in the same way. But the coverage does have to be the same in terms of the services that are provided. Now, the most common or prominent choice is the Medicare HMO, which is basically a sort of classic capitation insurance plan, right? Paying on a per person basis, very much like the managed care plans we saw before. But there are also Medicare PPOs as well as fee for service plans, but they are less popular than the HMO, which is probably a good thing, especially the fee for service, right? As we saw last time, when doctors get paid on a fee for service basis, there's opportunity for induced demand, and there's other problems in controlling costs. So it's probably a good thing that that one's not very popular, right? These PPOs and the HMOs, the managed care type plans are going to help save money and provide basically the same levels of health outcomes. So it's probably not a bad thing. All right, so the way that it works is that Medicare pays a fixed monthly amount per person to these HMO plans. The plans provide all Medicare needed, and the capitation payment varies by region. So it'll depend on sort of the demographic mix, as well as the regional cost structures that are going on. And importantly, it includes higher payments that are known as risk adjustments for people that have more expensive medical conditions. So for those people that have these more expensive medical conditions, there's a higher payment that is labeled a risk adjustment. And so since its creation, enrollment has been growing steadily. And it has been even more popular since the risk adjustment mechanism was added in 2004. So to give you an idea of how popular it is, about a quarter of all Medicare enrollees take advantage of this Medicare Advantage Part C edition. And of the 12 million people enrolled in Part C in 2011, about 2/3 were in the HMO type plan. Okay, so so let's see. If 12 million were enrolled in Part C, that means that about 48 million are enrolled in Medicare, right? So about 48 to 50 million in Medicare. 12 million of those people are in Part C, and of that 12 million, about 2/3 are in the HMO plans. And then everybody else is either on a local or regional PPO. Or fee for service, although I think the fee for service ones have pretty much died out at this point because of the problems we've seen with them. All right, so more on this risk adjustment aspect, right? So like we've said already, the Part C payments use the average adjusted cost per case, and these adjustments are made on regional cost differences as well as demographic mix differences. So of course, people in different demographics are going to have different medical needs, and those will come with different medical costs. So there are adjustments made on those avenues. And so it was a pretty basic risk adjustment up until 2000, when the policymakers in charge of Medicare decided that a more refined, finely tuned risk adjustment measure needs to be implemented. And that would be implemented slowly over the course of 4 years between 2000 and 2004. Now, at the time of the phase-in, so in 2000, it was pretty obvious at that point. There had been plenty of research done at this point on HMOs and all that sort of stuff. And so at this point, it was pretty clear that people on the HMO plan were actually healthier than the average Medicare population. So that's not surprising. That falls directly in line with what we saw with managed care, right? Managed care not only saves money, but it generally provides better outcomes. So that's not too surprising. Um, and before the risk adjustment procedure began, these HMO plans actually increased total program expenditures. So expenditures were actually increasing before these risk adjustments had been begun implemented. And that was mainly because the program paid, remember, the program pays an average cost per enrollee, but patients are healthier. So, so how does that lead to higher costs? Well, the it's a fixed payment, so it doesn't ultimately matter what needs to be done in terms of the care that's provided. The average cost is just fixed, and will fix at a given moment in time, and that's what they get paid per person, right? But of course, these people in HMOs are healthier, so they don't need as much care. But the payment to the service provider is fixed, and so that's actually what led to these increasing costs, even though these patients are healthier. So, intuitively, we would expect healthier patients, lower costs, but because the payment scheme was just an average cost per person, the expenditures increased. That's actually what was sort of the impetus for these changes in terms of risk adjustment, right? So as these changes were being implemented, um, the Medicare capitations fell significantly at this point. Now, some of this was actually because some of the insurance providers providing the HMOs decided that it was no longer worthwhile being part of the program, and so they left. And at the same time, there was some loss of enrollment. So some people dropped out of the plan because um, they viewed the risk adjustment changes as somehow an inconvenience or not worth it, and so they decided that they would no longer be enrolled in the HMOs. But as the risk adjustment became implemented slowly over the 4 years, people realized that the changes weren't that degradatory to their insurance coverage, and so enrollment started to tick back up shortly after. And I think this is numbers from 2012, but in 2012 there were now more than 12 million people participating in Part C. So we can actually see this in Figure 12.1, which we'll look at in the next slide. But it pretty clearly shows how the risk adjustment changes mattered quite a bit. So when we look at this next chart, we'll think about the time period, the couple of years before the change was made, so 98 to 2000. And so this was the range where Medicare was overpaying HMOs, right? Then the changes started to happen where payments fell, some plans withdrew, and enrollment started to come down. And then once the changes were fully implemented, and this more refined risk adjustment system was in place, HMOs were found to be more acceptable, and so not only did plans re-enter the market, but enrollment also started to increase, and that's pretty clear in the graph here. So you can see very, very clearly the whoops on my laser pointer. There we go, laser pointer. All right, so we can see very clearly that once the changes were starting to be implemented, the enrollment came down. Of course, that's going to be associated with a decrease in costs. And then by the time it was fully implemented, everybody calmed down a little bit and was like, okay, it's not that bad. This still works pretty well. And in fact, it actually works better. And so we see enrollment really start to take off. So obviously these changes mattered quite a bit. You can look at the pre-change levels and then the post-change levels. So obviously the changes made quite a difference. Although it did scare some people, right, initially. All right, now let's look at SCHIP, right, the Supplemental Children's Health Insurance Program. So this was enacted in 1997 under the Bill Clinton administration. And it was created really out of a concern for what was considered to be a high rate of uninsured children. So um, this was pretty concerning. Now, of course, um, Medicaid covered some low income children, but there was kind of a gap. Um, so there were some families that basically made too much money to be eligible for Medicaid. Okay, so that let's try to keep these straightforward, right? Medicaid is for poor people. Medicare is for old people. Okay, so here we're talking about Medicaid. So there were some families that basically made too much money to be eligible for Medicaid, but they didn't make enough money to buy their own private insurance, right? So there was kind of this gap um, for low income people that couldn't buy their own private insurance, but weren't so poor that they could get Medicaid. And so that was really where the concern was coming from, was kind of this gap that was created. Um, and so S-CHIP works very similarly to Medicaid. It operates in terms of federal state partnerships, and each state designs its own plan. And the federal government sort of lays the ground rules and assists with funding. So on average, states pay 30% of all expenditure. And of course, the federal government pays the other 70%, but that's just an average. It actually varies from state to state. Um, so part of the rules are that there's a higher sharing rate for states. You can kind of think of it like co-insurance, right? There's a higher co-insurance rate for states with higher per capita incomes. Okay, so states like California and New York have to pay they get a lower percentage from the government, right? They get only 65% of their expenses covered by the federal government, while lower income states like I don't really know which ones they are, but I'm guessing like Alabama and Mississippi, they get as much as 85% from the government. Okay, so that 30-70 split is just an average. It varies from state to state depending on the state's income per capita. And so states kind of have three options provided by the federal government. So um, they have three different options here. They can either provide S-CHIP through their Medicaid, their already established Medicaid program, or they can establish an entirely new program, or they can kind of blend some combination of the two. Okay, so those are their options. Um, And really, the way to analyze the effects of these programs is to kind of look at uninsured rates before the program and then after the program to get an idea of the effectiveness. Right now, unfortunately, the program has really only eliminated less than 1/3 of uninsured children, which amounted to about 3 million children. So that's good, right? That's a step in the right direction. But ideally, we would hope for something closer to 100%, right? So 1/3 is not great. Um, and there's another issue that kind of came about, and that's basically crowding out. So the program also unintentionally provided a substitution for private insurance. So people that would otherwise buy their own private insurance became eligible for S-CHIP, stopped buying private insurance, and went into S-CHIP. So these 3 million children that were not uninsured previously, they had insurance previously through private insurers. After the program was implemented, they then switched to S-CHIP. So basically crowding out, right? Crowding out. And this was actually central to the debate that went on in 2007 when this program came up for reauthorization. So it was only in 1997 when it was created, it was only laid out for 10 years. And then after that 10-year period, it would have to be reauthorized. Okay. So in 2007, this was a huge issue that was up for debate, right? Well, we created this program. Yes, we were able to get some uninsured kids insured, but we also kind of created another problem with this crowding out issue. So maybe how can we fix that, right? So that was a huge debate. So the original program was targeting families that were at or below 200% of the federal poverty line, with some exceptions. Um, most most states adopted the 200% rule. Some states decided to have higher limits. Some states decided to have lower limits, the lowest being 140% FPL. And a lot of states were requesting an expansion, right? They wanted to expand these benefits, try to cover more of the gap, right, between people, try to cover more of this gap for people that were not poor enough to qualify for Medicaid, but were still poor enough that they didn't have insurance for their kids. So a lot of states wanted to expand this a little bit further, right, up to almost 400% FPL. And in fact, the legislation that was passed included this expansion. But at the time, George W. Bush decided that that wasn't a good idea, and he actually vetoed this twice. And Congress wasn't able to override his veto. So the expansion never took place. And you know, it's debatable as to whether that was a good idea or not. It certainly probably would have exacerbated the crowding out problem, but it also would have probably helped insure more uninsured children. So unfortunately, I guess we'll never know. But the whole debate that took on was centered on this crowding out issue, right? The fact that government spending was pushing out or crowding out private expenditure. And like I said, increasing eligibility would have probably made it worse. And so the issue really became how much crowding out is happening, right? How much crowding out is happening, and it really hinges on sort of the subtle difference between substitution and crowding out. So let's think about that a little bit more, right? Substitution, in its purest sense, really implies completely dropping private coverage once public insurance is obtained. So that would be what we consider substitution, right? Just swapping one thing out for the other, and completely leaving the thing that was substituted behind, right? So to try to get an idea about whether this was substitution or crowding out, there was one study that saw that in New York, so the New York S-chip program, they found that there was only about 7.5% of enrollees that dropped their private insurance coverage. So this would constitute substitution, right? So it seems like, at least based on this figure, that the substitution issue isn't that bad by itself, right? Crowding out is substitution plus more, right? So it includes direct substitution, but it's also anything that potentially reduces the use of private insurance. Okay, so it's a bit, crowding out is a bit broader, right? It includes direct substitution, but also other things. So an example of crowding out would be perhaps somebody that changes jobs and their first employer offered insurance coverage that included coverage for children. But their new job, which maybe, of course, offers higher wages, but doesn't include coverage for children, right? So this would be an example of where there's crowding out going on, okay? Because the private insurance isn't being dropped entirely, right? It's being reduced because of the job change, and the reduction really comes in the form of not including coverage for children. And so then, of course, they enroll in S-chip, and so there's not an entire substitution, but there is crowding out going on, right? So that would be a good example. So it is a very subtle difference, but it's an important difference. So the Congressional Budget Office actually has an estimate for this, and they estimated that between 1.25% of the S chip enrollment represented crowding out. So that's pretty substantial. Another study that was sort of broader in its assessment of crowding out estimated that rates could be as high as 60%, which isn't terribly far off of the CBO's estimate. If you look at the higher end of their estimate, one half, 60% is just a little bit higher than that. But and then of course if the increased income limits had come to fruition, it would have been even worse, perhaps as high as 34 to 42% crowding out in the lower group, the 200% FPL group, and then perhaps as high as 54 to 60% for families in between 200 and 400% FPL. So crowding out seems to be a real issue, a pretty substantial fraction of enrollees. So, of course, what does this mean for us as economists, right? Well, we're always thinking about things in terms of efficiency, right? And with regard to public programs, we're thinking about how efficiently the government achieves its public goals, right? Its public programs, how efficiently does the public program achieve its goal? So for us, crowding out is a form of inefficiency. But so is paying for people that's paying for things people would buy on their own, right? So subsidizing things that people would just buy on their own is another inefficiency. There's also another inefficiency that we've talked about, and that's the subsidy, the income tax subsidy for private insurance, right? That's another form of inefficiency. So it's not like this is anything new necessarily, right? This crowding out, while it's an issue, is very akin to several other inefficiencies in public programs as well. And so these are all issues that arise in almost any type of discussion where there's government involvement, where there's a private alternative, right? So, so while it's an issue, there are other similar forms of these issues as well. So probably something to try to work on. I'm sure that as we move forward into the future, and this S chip is reauthorized again in the future, I'm sure that these will be things that will be targeted, right? How do we reduce the crowding out? All right, and then the last addition that we need to talk about is Part D. And what Part D does is that it adds the addition of prescription drug coverage. But it does sort of create a couple of quandaries. One question is, why wasn't this part of the coverage initially in 1965? Why is drug coverage desirable now and it wasn't back then when it was created? The answer to that first question is relatively straightforward. And then there's this other very strange question regarding this sort of donut hole in coverage, and we'll talk about what the donut hole is. And it's kind of a very strange design element, but it kind of makes sense in some ways. So we'll see what that is. But with regard to this first issue, right, why is drug coverage more desirable today than back then? It's mainly because in 1965, most drugs were being given in hospital. And so they were already covered in Part A. Out of hospital prescription drug use was not common like it is today. So that's really the answer to the first question, is that it's just that hospitals, drug use was mainly taking place in hospital, which Part A already covered. So there really was no need to have this extra coverage. On top of that, there were very, very few high cost drugs used as a treatment of choice. So these two things together really didn't create a need for Part D. Right? There was no large financial risk for out of hospital drug use. But then technological change, right? The the theme to so many stories, technological change, right? So of course, over time, um, new drugs were being developed that were targeting a wide array of illnesses, right? So things that weren't just for um, hospitalization, but drugs that could be taken, day to day in everyday life that helped all, a broad array of ailments. And as they were being developed, a lot of them turned out to be relatively expensive to develop, of course, right? If you know anything about the pharmaceutical industry, it takes millions and millions of dollars to develop a drug, and perhaps many years, maybe even a decade, right? So the development of these drugs can be very expensive, um, and so basically there was a creation of a new types and uses of drugs, which also created new types and not only new types but significant types of financial risks. And we all know what happens when there's financial risk. There's that creates a demand for insurance, right? Um, and the real problem is that these newer types of uses for drugs aren't covered in the original Part A medical per capita spending, right? So they weren't covered, but the financial risks evolved, and that, of course, created a demand for insurance, right? Um, so by the time Congress started considering drug coverage in Medicare, private insurance had already been on this boat a while. They've been providing prescription drug coverage for some time, um, and then Medicare finally caught up several years later. And again, this really was compelled by the fact that there was increasing risk um, for drug coverage, right? Not only were these newer drugs very expensive, but they were taking place outside of the hospital. And additionally, private insurance had been starting to cover these drugs for some time. And so it became obvious that, okay, maybe this is something we should include in Medicare as well. And so that's really what created Part D. And it was the first broad prescription drug coverage within Medicare that ever took place. All right, so now for that second question about the about the donut hole. So to understand the donut hole, we really need to understand how Part D works, and it does have this very unusual design feature. Um, and really, the purpose for this unusual design feature is it's an attempt to balance um, usable insurance coverage for drugs while simultaneously controlling spending. Right, the common dilemma here with insurance, right? And so basically, the program offers catastrophic protection, and so this helps people that have very large annual drug expenses, um, but then it leaves out sort of intermediate groups, intermediate to large expenses, and so that's really where the donut hole is. Um, and so this is really designed to control costs. Now, there may have been other ways to try to control spending, but the designers of Part D were really trying to immediately affect many, if not all, Medicare enrollees all at once. And so this is what led them to create the donut hole model, right? Balancing something that is going to be useful for people, but at the same time controlling costs. Okay, so there's several terms here. It's a little bit complicated because of this donut hole feature, but basically, this plan starts with a deductible, and then there is what's called an initial coverage limit. So there's a first limit. Then after the initial limit, there's what's called the out-of-pocket threshold, and then after the out-of-pocket threshold, there's a total out-of-pocket limit. Okay, so there's all of these tiers basically: deductible, initial coverage limit, out-of-pocket threshold, out-of-pocket limit, and you can see the dollar figures associated with each of these levels. Okay, so the way that this works is that each enrollee pays the deductible of $320. That was in 2012. After the deductible is reached, the plan then pays for 75% of costs up to the initial limit. So up until that $2,930 limit. So from $320 up to that limit, Part D covers 75% of costs. Then is the donut hole. Okay. So up until this point, at that initial limit, the enrollee then falls into this donut hole. And you can kind of think of it as a second deductible. So the enrollee is basically not covered once they hit that initial limit until they hit the second out-of-pocket threshold. Okay, so this gap is acting as the second deductible. So there's no coverage between this initial coverage limit and the threshold. And so it's acting like a second deductible. Then at that point, once the enrollee hits this out-of-pocket threshold, the government then basically covers 95% of all costs. So this is the catastrophic coverage, right? For people that have really large drug expenses. So once a person hits that out-of-pocket limit, basically almost everything is covered. They only have to pay 5% of anything beyond that limit. Okay, so do you guys see the donut hole, right? There's coverage over here, there's coverage over here, there's something missing in the middle, right? That's why it's called a donut hole. So to think about this slightly differently, perhaps more concisely, the coinsurance rate is 1 for any spending between $0 and $320, right? So that represents the first deductible. Then the coinsurance rate is 25% from that $320 up until the initial limit. Then the coinsurance rate goes back to 1, so fully uncovered, right? That's the donut hole. And then once they reach that out-of-pocket limit, it's almost full coverage, right? Coinsurance rate's only 5%, right? So the third bracket here represents the donut hole. Another interesting design feature of Part D is that the plans are administered by private insurance companies under federal guidelines. And the rules are applied more favorably to people that are below the federal poverty line, as well as those that are dually eligible for Medicare and Medicaid. And there are also state and federal subsidized premiums. And most private insurers offer plans that eliminate the donut hole. So not only are private insurers administering these plans, they also provide supplemental insurance to people to cover the donut hole, right? So just to give you an idea of the donut hole coverage that is offered, basic prescription drug plans typically start somewhere around $15, while these plans that cover the donut hole cost about $130 a month. Okay, so these donut hole coverages are not part of Plan Part D, right? They're not part of Medicare. They are purely private offerings, right? So these offerings are what are called Medigap insurance. Okay. Oh no, sorry, this is something else. Although maybe we could call them donut hole coverage, right? But there's another kind of gap in Medicare in Part B. Okay, so this is a different gap, separate from the Part D coverage. So it's kind of funny. It's ironic because Part B is called supplemental insurance, and it's voluntary, right? Recall that it's voluntary, but it's so heavily subsidized that basically everybody becomes a part of it. But there's this meta gap. There's still this gap that takes place that um, um, that private insurance provides a supplement for. And there's about 10 million people that are enrolled on this Medigap insurance. And it's called so because there's sort of these large gaps in Medicare's coverage. Okay, so one of those gaps we've already seen. So that's Part A, right? In the Part A part of Medicare, which covers hospitalization, we saw that if you hit this limit of 150 days, you're no longer covered. All right. That's a huge gap, right? That's a huge gap that people might want to fill. So that's one thing that Medigap insurance can cover. Another gap is that while there is coverage for that first 150 days, the daily co-payments can be quite large and can in fact increase with length of stay. So that's another gap that Medicare is sort of failing to cover is these co-payments. So that might be another reason for somebody to buy private insurance that covers these types of gaps. There's also a gap in Part B, and that's most notably with these sort of open-ended 20% co-payments for physician and surgeon fees. So those can be quite large, right? 20% can be a large number if the procedures are expensive. And then, of course, also the other gap we've already talked about with Part D, which is the fact that at least within the original program, out of hospital drugs were not covered, right? So these are all the sort of gaps. Of course, Part D took care of this last gap, but before Part D, prescription drug coverage was not available except for in-hospital drug use. So Medigap helps to fill these gaps, right? And because of the different nature, right, all of these gaps are sort of different in their nature. So of course, there's a large variety and complex variety of choices for these Medigap insurance types. And the premiums for these plans will vary according to the plan. And they also vary regionally because of the cost variation regionally as well as the demographic variation. And lack of competition can also play a role in variation of cost across regions. So of course, some rural areas, there's going to be very low competition. So these are private plans, right? So of course, they might be more expensive where there's less competition. So really the key issue here is the underlying risk that remains within the standard Medicare program. Now, if the Medicare program had good stop loss provisions, which are basically sort of catastrophic provisions, right? Capping what a particular individual could potentially lose, then probably relatively few people would bother buying Medigap insurance if Medicare provided these sort of stop loss provisions. But they don't, right? Although Medicare HMO plans do create a stop loss feature through sort of other mechanisms. And researchers have found that higher Medigap premiums in a region leads to more Medicare HMO enrollment, which is not surprising, right? So, so just to kind of think about that a little bit more, anywhere that there are these HMO options available, and there are also higher Medigap premiums, people are just going to opt for the HMO because they have these stop loss mechanisms, right? Which is really what people are seeking. They're seeking a way to cap their financial risk, right? The most money I want to lose is X amount, right? I don't want to be at risk for any further losses than that. That's what a stop loss is. And so HMOs, the Medicare HMOs provide that. So in regions where Medigap insurance premiums are really high, people are just going to opt for the HMOs instead, right? And then there's one other feature of these Medigap plans that reflects an important economic issue, and that's the issue of self-selection, right? We've talked about that before. Um, People are self-selecting these plans, right? So given that, there's always the risk of bad risks chasing good risks, sick people trying to pretend that they're healthy people, right? And if that happens, there's a possibility that the Medigap market could unravel, because if the sick people can successfully pretend like they're healthy, the insurance companies are not gonna make money, right? They're gonna pay out more in expenses than they collect in premiums. So the market would fail if that happened. Now, there are some regulations on Medigap insurance. Medicare requires that Medigap insurances have the same standard coverage definitions, um, but it's also required that they offer annual periods of open enrollment, very much like Obamacare, where anybody can enroll in the program for the same premium. And so this is basically effectively creating a community rating, right? We talked about community ratings earlier when we talked about the supply of health insurance, as well as the demand for health insurance. But this is basically creating a community rating, right? Where everybody gets the same premium, regardless of how healthy they are, right? And so this is really a good example of regulation that's attempting to improve market functioning when there might otherwise be a market failure, right? So that's Medigap. All right. Are there any questions from anybody so far? Okay, cool. So that's all I had for you today. We got through that pretty quickly, a little quicker than I anticipated. So, but for next time, we're going to wrap up this chapter. We're going to look at some operational changes that have taken place in Medicare. And so that's quite a bit of information. That'll be probably the majority of what we talk about on Wednesday. And then we'll also talk about Medicaid, which is the government provided health insurance for people that are low income. And then that'll be it. That'll be it for the whole semester. And then, of course, you guys have your third exam coming up this weekend. So make sure you're thinking about that and getting prepared for that. It covers the last 4 chapters, including this one. And then, of course, you have the optional final exam, which if you're planning on taking that, go ahead and get prepared for that as well. But that's what you have coming up. And then I think for this chapter, I'm going to make the homework optional. Since we have the third exam and the final exam coming up, I'm going to make this homework optional and basically drop your lowest homework grade. So so that if you missed a homework previously, you can do this optional one and make up for it. So so that's the plan. Are there any questions about anything? No? Okay, cool. All right. Well, if there's no questions, I'll let you guys go. Try to have a good day with all this rain and weather. Stay safe, and I will see you on Wednesday. Bye.